I apologize for this technical failure, but well, I think our discussion would not be complete in our session devoted to the patient-oriented approaches in the healthcare without the discussion of the quality of life of the patients. I think this is very important. So this bridge to the quality of life, this is the title of the symposia, patient-oriented healthcare. Patient-oriented healthcare, what does it mean? So these are main parameters that I'm going to now, and by that I mean the quality of life of the patients per se. So the International Expert Advisory Board, Patient for Care, means that the priority is not just the physical well-being of the patient, but also psychological health of the patients. So positions and proper level of cooperation between doctor and the patients. This is interaction with the family members. This is interventional support, training of the patients, and participation of the patients and family members in decision-making.
Точно пересекаются с понятием качества жизни, которое подразумевает под собой.
And this is interaction with the quality of life. Physical, psychological, and social well-being of the patient based on his or her subjective perception. This is related to the definition of the health by WHO. So quality of life is something related to the health, and the most important, the quality of life should be how it is assessed by the patients. If we speak about, if we speak about hematological diseases, well, definitely such aspects could be influenced by subjective symptoms related to the disease itself and also with the treatment. Let's say nausea, vomiting, fatigue, dyspnea, suppression, so subjective symptoms, quality of life, and some other standardized positions. They are united by the expert position in the assessment of the patient. These are patient-reported outcomes. And if we go back to why it is important to assess the quality of life of the patient with the oncohematological disease, we actually go back to 30 years back to the consensus conclusion of American Society of Clinical Oncology and the National Institute of Cancer of the United States that actually identified the priorities and the following efficacy. So the first and the key thing here, that's overall survival, and the second significant one, it's a quality of life of the patients. And then the optimal search, that's the balance between the prolongation of life and also support and preferably improvement the quality of life. If we speak about new drugs, FDA and it means that the data should be presented not only in the clinical efficacy about the life expectancy, but also for the quality of life of the patients. And here on the slide, you see some information about FDA guidelines of 2009 for pharmaceutical industry about the assessment of patients in the registration of the medicinal products. So if we say in what cases and why and when we can use this method of quality life assessment in oncology, hematology, and in some medical directions, these are clinical trials. These are phases 2, 3, 4. And in the clinical trials, the quality of life is an additional criteria of the efficacy. And there are studies and there are examples on the quality of life. Today, in the international community and also in our country, we have some experience using quality of life assessment, specifically symptoms of the clinical practice. But what I think the most important and very perspective, these are observational perspective studies of the quality of life in the real clinical practice. Why is it important? because the inclusion criteria is such observational perspective studies are wider than in the clinical studies. So we can get information about the quality of life when the patient is getting real treatment in the real routine clinical practice. In such studies, the quality of life can and normally is the main criteria of the efficacy of treatment. What is also important, it's direct involvement of the patients at the stage of adaptation of the questionnaire on quality of life that later on can be used in such observational programs. Another key thing, we get information about the quality of life in the national population of the patients because we understand that the quality of life is due to the cultural and social aspects. And that is why information about the dynamics of the quality of life is very important if we have some data in our national population of the patients. In other aspects, in such studies, we can analyze the quality of life of patients in different groups. For example, identify the group of elderly, patients with comorbidities, and to identify and select factors that influence the change of quality of life in the process of treatment. Summing up the importance of such programs, we can say the following. Such observational programs of quality of life, that's the only way how to assess the risks and advantages of treatment from the point of patient himself. That's opportunity of active role of patients in the assessment of results of treatment. That's active involvement of all parties, including patients, into the decision making. And definitely, this is a justified method of using data on the quality of life obtained in such programs when preparing regulatory solutions and designing clinical guidelines. As an example, I would like to show national program of the quality of life of the patients with myeloproliferative diseases and attitudes to the issues related to the patients and doctors. The results of programs that was done in 2020 with the support of Scope and Forum and with the coordination of the International Quality of Life Studies Center, they were published as a separate issue and big article in the clinical oncohematology. So 1,100 patients participated, 100 doctors, hematologists, and from different regions of the countries. But let me draw your attention only to some aspects. So we used very modern surveys. They participated in their testing. This is HPRO for the assessment of the quality of life of oncohematological patients, and then NPN10 for the assessment of symptoms of the patients with myeloproliferative diseases. And, well, they were quite interesting results. Well, I fully understand we have no time on that, but this slide demonstrates us that we studied specificities of quality of life, unresolved issues, open needs of the patients with different myeloproliferative diseases, and this program is an important contribution to the increased awareness about the challenges in the treatment of patients with myeloproliferative diseases and attract attention to the unmet needs of the patients. This information helps to understand better the challenges that patients with myeloproliferative diseases can meet, and then to use it for the improvement of the quality of care. And now two moments that I want to identify. We saw that in the true polycythemia, doctors underestimate reduction of quality of life and the influence of symptoms. We found some unresolved issues of patients with true polycythemia, and we designed new study, new prospective follow-up program of the changing of the quality of life and the symptom with true polycythemia that are getting rock solid in the real practice. So this is a program that starts in October this year with the support of Novartis, and we are hoping to use the following standardized questionnaires. So that's general questionnaire on the quality of life, then symptom assessment for the myeloproliferative patients, MPN10, then general self-care scale and satisfaction of treatment scale. And as I said you before, that would be prospective, and the patients would fill in these questionnaires before the start of treatment and in different timelines. In order to meet the timing, let me come to the conclusion. So the studies of the quality of life in oncology, in hematology, in the real clinical practice. So this is opportunity to increase the role of patients in decision-making and to include into this process all parties. This is option to get information about the quality of life in the national population of the patients with hematological and oncological diseases. This is option to improve the interaction between doctor and patient and to improve quality of care via active communication and cooperation by the doctor, patient, and his relatives at all stages providing medical care. This is increased awareness about the challenges related to the disease and to the treatment. This is relevant for the quality of life, and this is attraction of attention to the unresolved needs of the patients, open needs. And last but not least, data on the quality of life of patients obtained in the real clinical practice is scientifically justified and should